to Professor Tim Trish and the USWOC webinar team for inviting me to present this lecture, Pathophysiology of Sclerotic Pregnancy from the Practicing OB/GYN MFM. There is strong evidence that many placenta accretum spectrum cases originate from an implantation development of a pregnancy inside a previous cesarean section. There is also strong evidence showing that the number of cesarean sections increases risk, probably because it increases the risk of scarification and development of large scar defects. When we perform a cesarean section, we should not fool ourselves. We are inducing what we call a forever scar in all the patients that we operate on. Of course, for the patient, it's a skin scar that's important, but for us obstetrician gynecologists, it's a uterine scar in the lower uterine segment because it can develop into this niche or scar defect. Not to also mention that in about half the patient, we induce a formation of pelvic adhesion, but this is another lecture. I enjoy very much understanding the mechanism of disease, which is why this lecture is particularly exciting for me. Anything that's related to placental disorders is something that has always interested me. And if you want to know more about the content of my presentation, I invite you to have a look at this chapter in Robert Silver's book and this expert review published recently in the American Journal. Now, what happens when we cut the uterus and we induce a scar? The problem is that the muscles, including the myometrium, do not heal by regenerating muscular fibers. So the scar area will actually be made of collagen, tissue edema, inflammatory cells, elastosis, and more of concern for the next pregnancy, myofiber disarray. The lower uterine segment in particular is more vulnerable because it is thinner and contains less muscular fibers. It is designed, like the cervix, to expand and dilate, and it provides minimal contractions. It is not its purpose, and thus it does not contain many muscular fibers. You can see here, once you reach the lower part of the uterus, you get less than 20% of fibers, and when you reach the cervix, it is less than 10%. So the scar tissue is thinner, it's less elastic, it's more prone to injury than the intact muscle. And so you are likely to develop at some point a scar defect, but also adhesions during pregnancy, which increase in the third trimester with Braxton Hicks and the pressure of fetal presentation. And finally, there is a risk of rupture, and antenatally, it's very rare. Intrapartum, in case of a tridal scar, is about 0.5%. So the scar defect has its own epidemiology. It's defined as the loss of most of the uterine wall with residual myometrial thickness of less than 2 millimeters. I'm sure that you will hear this in other presentations today. It affects 40 to 70% of pregnancies, depending on the number of prior cesarean sections. And it's more common in patients with retrobaric uterus, with a location of the scar in the low part of the low uterine segments or the cervix, which happens sometime. The surgical technique, single layer, incomplete closure, locking suture, emergent versus elective, is still the matter of discussion, and there are not enough data to be conclusive, in particular on the surgical technique and the different type of suture material use. So what is the pathophysiology of this scar defect? This is a very interesting study published a decade ago by an American team looking at the scar area in 7 hysterectomy specimens from patients with prior cesarean section. And they are the ones who have described this myofiber disarray, the elastosis, the tissue edema, the inflammation, but also myometrial hyperplasia in some area with keloid-like reaction, a bit like in the skin, and the development of adenomyosis. So basically, these scars completely disturb the normal anatomy of the area that's been damaged by surgery. And they define this as marker of aberrancy in wound healing after iatrogenic uterine trauma. This is a study from a French team, which is more recent. It's 8 hysterectomy specimens from patients with prior C-section, where they also sampled the area of the scar, as you can see here. And it's very interesting to find that the endometrial mucosa lining these niches are often show disorganized pattern resembling perimenopause. So basically, they do not recolonize the area the way they should in a normal intact uterus. And you have a regenerative epithelial atypia and fibroblastic stromal reaction, which is also something that you would never find in an intact uterus. And then finally, this publication I find really fascinating from 2009, which took cross-section observational samples from endometrial tissue in 11 patients with prior cesarean section and 16 controls who had normal vaginal births. And there was significant fewer leukocytes in the endometrium in the secretory phase at cesarean section site than in controls, suggesting that the low uterine segment scarification affected leukocyte recruitment to the endometrium, and more importantly, the reepithelialization of the scar. And as you can see here, this is a patient who's had several cesarean sections. You can hardly see the endometrium in the area of the niche. So what happens when the patient becomes pregnant? If she's very unlucky, in about 2,000 pregnancies, she's going to end up with a scar pregnancy. It's very interesting to understand why this happens, why the creation of this scar actually favors, in many cases, the implantation development of the placenta in the scar area. Is it the interaction between the blastocyst and the endometrium, which is altered? Is it different signaling? Is it different flow? Is it a slowing down the flow in this area? But whatever the reason, it's also interesting to find out that once you've had a cesarean section, you are twice as likely to have a placenta previa. And if you have a placenta previa, this is obviously the start of a scar pregnancy. Now, if you have had 2 cesarean sections, you have the number effect, and it increases obviously with the number of cesarean sections before your pregnancy, then you increase that risk. And if you have IVF, probably as a result of flow effect, you increase this risk by at least 3-fold. Does the size of the cesarean scar defect matters? Nobody really knows. I couldn't find any data on this. I think it's an important question, which certainly will determine the way we manage these scar defects. Now, to go back to IVF pregnancies, obviously when an embryo is being transferred, the catheter is being put as high as possible inside the uterus. But it is done in the second half of the cycle when you have a change in the flow in the uterus, where you can see that this flow suddenly, instead of going from up to down to favor the fertilization, goes from this part of the uterus, which is the fundus, down to the cervix. So there is an inversion of the flow in the second half of the cycle, which obviously naturally brings down the blastocysts that you have transferred closer to the lower part of the uterus. And then these transfer are associated with blastocysts that will not have been interacting with the upper part of the endometrium. And so the combination of changing the flow, the scar area, and the blastocysts' lack of interaction with the upper endometrium may explain why there is such a high incidence of scar pregnancy and placenta accreta in IVF pregnancies. There's a lot of discussion about upper uterine segment placenta accreta or scar pregnancies or non-previa placenta accreta spectrum. Now, this study I find very interesting. It followed up patients who had had myomectomies and patients who had had prior cesarean section in a classical manner, which is basically the old way of cutting the uterus in the upper segment. And they found no case of placenta accreta spectrum in the prior myomectomy group. There was only one case in the classical cesarean delivery group. And this paper has reviewed the literature of myomectomy scar pregnancies and found only 8 cases, including the case reported in this publication. Now, there is no doubt that you can develop a scar pregnancy probably and then a placenta accreta if you've had a surgical termination that has perforated the upper segment. This is a case that I have been following up, and I've had 4 or 5 in my career over the last 25 years. So this is a fact. You can have a scar pregnancy there, and you can have a placenta accreta. It's also possible that in some uterine anomalies where the uterine wall is so thin that the placenta develops very close to the peripheral uterine arteries branches, you can also have the development of a placenta accreta. This is not truly a scar, but in any case, there is no report of scar defect or niche in the upper segment because you're dealing with the myometrium, as I said earlier, that's much thicker, and you have a much higher risk of uterine rupture during pregnancy or labor than you have of developing a pregnancy in the area. So what happens next? Now, fortunately, the vast majority of scar ectopic pregnancies will present as a miscarriage. And this may be due to the high velocity blood flow, which are dislodging the trophoblastic plug, which normally prevent too much blood getting into the placenta at this stage. So you have a massive and premature entry of maternal blood inside the primitive placenta with excessive oxidative stress, which leads to the development of the miscarriage, which is very similar to what we found in intrauterine miscarriages. And here I've been comparing the outcome of ongoing cesarean scar ectopic pregnancies in 2 studies. These are the only 2 studies that I'm aware of. Of course, there are not many cases. The study by Kelly et al. Is a systematic review, and our study is a cohort of 30 patients. It's not easy to compare the 2 studies, but what is clear is that the risk of miscarriage increases beyond the first trimester in these pregnancies. Quite a few patients will decide to have a termination of pregnancy because of the heavy bleeding. We had a case of fetal anomaly. The important point also is a risk of uterine rupture, which was described in both studies. And then, of course, the risk of developing a placenta accreta. In our series, we define this as placenta previa accreta. It is less defined in the systematic review. And the number of case reports that were included in the systematic review limits a little bit the interpretation, the analysis, but it is quite clear from these 2 studies that about half of these patients will end up developing a placenta previa accreta during the 2nd and 3rd trimester. Now, this is another very interesting study by the Timur Trish group, which has compared the development of a pregnancy on a scar and those developing inside a niche. And this is, again, the follow-up from our cohort studies. And the important finding in both studies is the fact that the myometrial thinning is less than 1 millimeter in those that presented with a placenta accreta spectrum in the 3rd trimester and at delivery, and those that require hysterectomy in the series of Professor Timur Trish's team. So in conclusion, not all cases of scar pregnancy will lead to a placenta accreta spectrum, about half probably. And the degree of the lower uterine segment and pelvic vascular changes, the development of a placenta accreta spectrum, plus the risk of 2nd trimester uterine rupture probably depends on the residual myometrial thickness. And we should be really wary about patients who have an RMT that's less than 2 millimeter, because they are at risk of these complications. Then it may also depend on the amount of definitive placenta tissue developing inside the scar area. And remember, uterine rupture is a possibility that is life-threatening, and please keep this in mind when you discuss with patient the possibility of continuing with the pregnancy after the diagnosis of a scar pregnancy. So I would like to thank all my colleagues who have contributed to this research over the last 15 years. It has been a very exciting time, and thank you very much again to Professor Tim Autriche and his